Greetings, salutations. Thank you for joining me for this Biostatistics, Epidemiology, and Research Design Core Special Topics Talk number 5, Designing an Epidemiological Study. I'm Dr. Mark Williamson for DaCCoTA. So let's jump in here. The goal of this talk today is to explore the basics of epidemiological study designs. And the reason we need to go over different designs is because there's several different types of designs, and the different ones have different pros and different cons. You don't use it for one for everything. And how you decide what design to go with really depends on your research target. Whatever you're interested in, you first develop and then turn to your study design after that. And before we get any farther, let's explain some terms from a textbook definition here of epidemiology, because that's important. Epidemiology is the study of how disease is distributed in populations and the factors that influence or determine that distribution. So there's a lot going on there in terms of how you would approach epidemiology. You might approach it from the disease standpoint, the treatment standpoint, risk factor standpoint, all sorts of things. So different designs will cover different types of answering those questions. So we'll jump right into those in the next slide. But first, I would ask you, if you could, take a moment to try out the pre-test to sort of assess where you're at coming into it. There'll also be a post-test at the end for you to sort of assess your understanding. All right, so we'll be looking at several different kinds, and it's good to note that there is a different weight of evidence. You could call it correlation, causality, in different types, as well as sort of broadly different types like analytical and descriptive, and we'll go into sort of those different definitions as we go through. Okay, so the studies we'll be covering are broadly described as either experimental, which include the randomized version, which is the clinical trial. There's different types, most notably parallel and crossover, but we'll look at sort of more the minutia there, as well as non-randomized or pseudo-randomized. These are the field and community trial. Now, on the other end is the observational. There's ones at the population level, which is going to be our health survey and ecological survey, split out by descriptive and analytic, as it were. And then the individual level, which is both, again, descriptive and analytic. We have reports in series under descriptive, and then for analytic, cross-sectional, case control, case crossover, and cohort. And then cohort in particular will be split down to two main differences of prospective and retrospective. So without further ado, let's dig into our clinical trial. It's great to start with clinical trial because this is often kind of the gold standard, or sort of the summation of a lot of research you want to get to. So another definition here, it's a research study in which one or more human subjects are prospectively assigned to one or more interventions, placebo or other control, to evaluate the effects of these interventions on health-related biomedical or behavioral outcomes. So that's nice, but another way to go about it is sort of to ask yourself questions about your research to see if they fit in the clinical trial paradigm. So first, does the study involve human participants? Second, are participants prospectively assigned to an intervention? This is a big key thing between observation and experimental. In experimental, the experimental is actually assigned an intervention, where observational, whatever happens, you just observe it. Okay, 3, is the study designed to evaluate the effects of the intervention on the patient? And then 4, is the effect being evaluated some sort of health-related biomedical or behavioral outcome? So if you kind of fit all those boxes, you are a clinical trial. And in fact, there can be some things that are surprising that fit that schema that you might not think as a clinical trial. So some great examples of clinical trials. One of the first double-blind controlled trial was Paladin for the common cold back in World War II. sort of probably what's on everyone's mind, COVID-19. Vaccine effectiveness, a lot of those are clinical trials to see how effective the vaccine are in the population. And then 3, this is an example of sort of a unconventional but fits the clinical trial formula. There's a study on radon risk versus smartphone app. So that's the idea of a behavioral intervention to look at a health-related income of, say, getting a radon test. So again, within this schema of clinical trials, there's a wide range of possible trial applications. They can be mechanistic, behavioral, etc. So really it just depends not so much on whether you're using a drug or not, but what the setup of your study is. Okay, and then again, this is kind of generally how you might schematize it. I'm using kind of red for people like cases, people like disease or something. You randomize it because that what sort of gives it its power. Some into a treatment group, others into the control group. And there's some really good pros and cons for this. So first of all, the clinical study is sort of the best for causation of like, yeah, this drug reduces this disease. The biggest causation. And it's also sort of clinical trials are where you get the translation of a lot of research into like, well, we did this stuff in the lab and it looks interesting, but clinical trials will get you from that interesting thing to, hey, we're actually improving patients' outcomes in real life. Now, some of the cons, of course, is feasibility. These typically take a lot of work beforehand, a lot of regulatory approval, time and expense. So these are usually the end stage of a large research sort of exploration project rather than any sort of start. All right, so because they're such a important part of study design, we'll go more into some of the more minutia of clinical trial. So again, just to clarify, this type of thing is both experimental and random. We'll see ones that are neither of those. Now, one consideration for your study design is the number of arms. That's kind of the idea of sort of how many different groups. Typically it's 2 arms, so you have a control and then a treatment. But you could conceivably have 3, maybe a couple different treatments. You could either have one where maybe you're treating something and then your control maybe is not so much a group, but like the general population. Another important piece is blindness. Sort of helps keep bias out of the results. So single blind is when the patient doesn't know whether they're getting, say, the control or placebo. Double is where the researcher doesn't know as well. And triple is not even the data analysts know who had what. Then the next thing here, which is pretty important in especially drug clinical trials, is phases. There's phases 1 through 4. Anything below that is typically called preclinical research, and that might involve animal models or other sorts of things like that. But anyway, with phase 1, you start with safety. It's the smallest, only maybe a handful of participants. The drug has to be improved first, but you typically look at safety. It's like, does this drug not cause too bad of side effects or what not? Phase 2 is safety and dosing, because then now you're trying to get the level of the drug right. This is a little larger. Even larger, phase 3, safety and efficacy. So now you're also looking at like, well, does this actually, how effective is this? And then after that, to get to phase 4, you need FDA approval. So prior to that, you don't. But then phase 4 is really kind of the sort of end stage where you're approved, the drug is approved, and now you're sort of surveilling sort of usually the more long-term effects in the population, and this is by far the largest. So then a big difference in design, main difference in design I talked about earlier is parallel versus crossover. So in parallel, each patient receives one treatment. So maybe they have the control with A and B as treatment. And so this is better, it's a little shorter term, but you need more patients to fill out both of these arms. However, in the crossover, each patient receives both treatments. So maybe they receive the control first and then later the treatment, or vice versa. And one feature of this is there's typically this washout period where you sort of wait in between the crossing over the treatment to sort of ameliorate the effects so close up. And these are typically longer term because you have to do 2, but it requires less patience, so it kind of depends on what you want to do. And another thing to keep in mind with clinical trials is the possibility of factorial design, where you might have 2 more treatments that are going on at the same time. So the factors mean whatever sort of categories, like treatment B and treatment A. So you could conceivably have someone taking both, one or the other, or neither. So of course, can be even more complexity, obviously layering all these things together. These are sort of important design things to keep in mind with our clinical trials. Okay, so now let's move on to our other type of experimental type of studies. However, these are no longer random. They're sometimes called quasi-random or just overall non-random. Now, field and community trials, sometimes you see in the literature they're called cluster randomized trials, which kind of means that they're quasi-random. But kind of what they're about here is a field trial is something that's more what they call field on the ground. This isn't usually in a hospital. This isn't the sort of clinical study, well-designed or sort of well-defined categories. It's generally brought on the general population. Population is generally healthy. It's more of an intervention to see if a risk of disease is reduced. And it's typically preventative in nature. So less controlled, but still trying to get the same sort of thing in general a clinical trial does. So a good example is the Gambia hepatitis intervention study. It looked at after people got the hepatitis vaccination for like long-term effects of possible like hepatocellular cancer or chronic liver disease, etc. And then the Minnesota Heart Health Program looked at the effectiveness of not so much a drug, but educational strategies on risk factor reduction. And they actually looked at, this is actually a community one, which is the logical extension of the field where you're including the whole community. This one used actually 3 communities as the intervention and then 3 as the control. So these field or community trials, they're really nice for early assessment, and you can see this might kind of blur the line where some of these sort of community or field sounds a lot like stage 4 or phase 4 clinical trials, and so there's a little bit of ambiguity there, but kind of getting at the general same thing. So some of the cons is obviously this is pretty high scale, so this is going to take a lot of cost, or it can. And then some of the causality is lowered because it's not truly randomized compared to the clinical trial. Okay, so that wrapped up the experimental side. Now we'll move on to the observational side. And again, the really big difference between the two is observational is the experimenters are not doing any sort of interventions. They're essentially simply observing. They might separate into groups to sort of compare the groups, but they're not giving any sort of drug. They're not telling them to do any sort of preventive treatment. They're just looking at what people may or may not have been exposed to or done or not done to see if they can kind of figure out the epidemiology of what's going on. So the first one we'll take a look at here is a health survey. So this is observational. This is descriptive, so it's really just describing what's going on rather than trying to analyze or answer a question. And this is at the population level, not individual. So typically they're survey, de-identified individuals maybe, but more often summarized by geographic or demographic. So you're getting a summary of a population, maybe a county level, maybe by some sort of bracket of demographics. And then these things typically have a large sample size, hundreds, thousands. And surveys can be a lot of different types of information. So the easiest one would be a questionnaire where people are asked health questions. but there could also be physical examinations, even like clinical data, like blood count, serum levels, etc. So some setup would be something like this. You have theoretically a general population. You survey as much as you can. Some will have certain diseases, others won't. So disease in red, kind of generally healthy or not disease of whatever you're looking at in black. So pros, obviously can be pretty wide scope and relatively easy recruitment in the sense of, especially some of these are pretty low impact. However, not a lot of resolution. It's better for more just like, again, a survey like, oh, what's kind of the lay of the land, rather than be able to answer specific conclusions. And so some great examples of this is the BRFSS, the Behavioral Risk Factor Surveillance System, and then the NHANGE, which is the Natural Health and Nutrition Examination Survey. So scuttling right along to our ecological study, which is a little bit confusing because this is ecological study in the context of epidemiology, because there's a whole field in biology called ecology, and they're of course doing ecological studies. So that kind of needs to be kept clear that this is an ecological study in the concept of an epidemiological study design. Anyways, very similar to the study design or health survey in the fact that it's observational, analytic, and population level. The difference here being analytic now, because health survey is just descriptive, like what's going on. Now ecological study seeks to answer questions by looking for associations between the occurrence of disease and exposure to possible causes. So really what they're structurally doing is taking a health survey and testing a hypothesis based on that survey data. There's a lot of common considerations that are used in ecological studies, maybe geography, like looking at county level rates compared to a certain, like maybe exposure, looking at time, demographics, maybe looking between like males and females or different ethnicities, and then socioeconomics, maybe looking at a disease across like income brackets or job descriptions, whatever. And so again, pros are scope, pretty wide scope, and relatively open data access. A lot of times these health surveys are open to the public, so anyone could do a design an ecological study theoretically. Obviously, resolution is pretty low because it's population level, and of causation because, again, it's pretty broad scope. Now, some examples of this, for example, there's a study on lymphocytic leukemia and radon by state to look at state radon levels, state leukemia rates, and found a relationship between them. Another one would be like vitamin D and cancer, where you're looking at kind of these broad geographic or demographic variables, and then looking at these specific questions. Okay, so design kind of here is you're actually taking not so much from the population but from a survey, and then studying all the sorts of things in that study. Okay, now let's turn to case reports. They're going to be observational, and we're back to descriptional, but now we're down back to the individual level here. So a case report is really just the details of a diagnosis, treatment, response to treatment, and follow-up with an individual patient. It's great for illustrating new or unusual features, maybe a strange response to a drug, or even more importantly, helping determine the cause of a disease outbreak. And it usually includes this demographic information, where a case series is really just the extension of the case report where there's 3 or more patients. So report 1, series 3 or more. Resolution is pretty great because you're really drilling down to the idiosyncrasies of one person and their response to something. However, it's hard to generalize with the scope. This is usually sort of like the start of a lot of things, and then you build up to a series and then kind of go up from there. So example, there's this NIH sort of example for training that the CDC has. It's on gastroenterosis at a University of Texas. Another example would be, say, in sort of more of the broader public understanding is like the discovery of HIV in the US that came through case series. Okay, let's turn over to our cross-sectional study. So this is observational, back to analytic, and the rest of these will be all analytic, individual level. So it's really one point in time, or sometimes called a snapshot. So if you think of the population as this cylinder, X and Y are, sort of different variables like demographics and disease status and blah, 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 and Z is your time. Your time here. A cross-section is like just taking one cross-section in time, no difference in time, to sort of capture these X and Y variables. So there's no follow-up. It's really just exposure status and outcome. So outcome was like, well, whether they have the disease or not. Exposure status is like, well, maybe some of the risk factors or things like that. And really, it's the weakest of the observational analytical designs. So it's really the best for prevalence. So just take a snapshot of the population, try to observe as many as you can, and then look at things like prevalence of disease. So relatively easy setup, good for prevalence, but bad for correlation, and obviously doesn't take into account time trends. So some examples here is like looking at study looked at bone mineral density in menopause. Another one looked at lung function, dust exposure in uranium mine workers. Okay, so now we have the CaseControl study, which again is observational, analytic, and individual level. And so you want to use this to determine associations between risk factors, exposures, and outcomes. So unlike the cross-sectional study, you actually kind of separate these into groups, either the cases and the controls, as we kind of see here. And then you like restfully look in the past for possible exposure. Now, of course, so you're doing it retrospectively, it's subject to recall bias. The cases or the controls, the patients might not be able to recall accurately, so you run into that risk. But this is especially good for like rare diseases with long latency, where it's hard to say like follow a group of people and then wait for them to develop disease if it's really rare, because maybe none of them develop it. So it's good to go and find people who already have it compared to appropriate group and look at that. So relatively easy setup, good for chronic disease. Once again, correlation is sort of hard for these sort of studies. Some examples, looking at like melanoma and UV radiation. Another study looked at, it's called the Long Island Glaucoma Study. It looked at glaucoma. And I believe things with like characteristics of the eye and like different pressure. So now we're going to talk about a closely related study design called a case crossover study. Again, observation analytic individual. It's very similar to case control, but instead of having two different like groups, case and control, your cases are your control, or they're the same individual. So it's more looking about triggers within individuation. So one individual, like say this one here, is both the case and control. So maybe you're still doing it at one time point, like you start here. And you look, okay, this person has the case. Well, let's look back to see when before they had it and kind of examine the difference between the two. And so you really need to set this up. This is kind of nice because then each individual serves as almost like the best control you could have because of the same person. But you really need to set up the period. Okay, when were they a case and when they were a control, and you need to set that up carefully. So great pros with case control match. Good, again, good for chronic disease. You need to still runs foul of the correlation issue and then takes more design. So some examples of this, study on elder mortality and temperature, as well as a study on fatigue and traffic accidents. Okay, now we'll get into one of the most powerful of the observational analytical individual level studies, the prospective cohort. This is in contrast to another type of cohort study is the retrospective. So cohort studies study cohorts, groups of people over time. The big difference is prospective starts with them and follows them over time, where retrospective takes a group that sort of have already gone through stuff and then looks back in time. So it's also called the longitudinal study, this prospective, or a follow-up study. So it's harder but more powerful than the retrospective. And so Groups are initially identified by exposure status. So this doesn't mean disease status, but exposure to something that you might think potentially causes disease. Say maybe this is people in general population. This is like factory workers, maybe exposed to asbestos or something. You identify them in group, and then you follow them over time. So you measure them initially, and you might measure them several times. I just have this twice, but obviously theoretically you could measure them many times over the years and see who develops the disease. So like, exposure here develops disease while other people don't. And now this is prone to things like selection bias, what really makes the groups different. Maybe there's some characteristics of these people who end up being in this group, like working in this factory, have certain characteristics that aren't shared by like the non-exposed group. But anyways, pretty strong when it comes to observational analytic studies on correlation, and you get to control this a little bit more. However, this takes a lot of steps, and this is by far the most expensive. But you can get some really great data out of here. Some good examples are the Framingham Heart Study and the Nurses Health Study, these long, multi-decade studies that gives us a lot of information about health. So on the backside of that is the Retrospective Cohort Study. Again, it's going to be very similar, but exposure and outcome has already occurred. So you're not looking over time. You're looking back in time. So it's a lot easier but less powerful than prospective. You really are making just one measure at this time, but then looking back and seeing how their exposure status, non-exposure status. And a common output of this is relative risk of like, well, if you were exposed to, say, working in a factory, what's your risk of having this outcome? And again, it's prone to selection bias, but then also recall bias, because you're asking the individuals to recall sort of what's happened. So some of the pros, compared to, say, the prospective, is easier setup and expense, but at the loss of control and some correlation. Some examples of this, a classic in like the beginning of the 1900s, Elaine Claypun's research on breast cancer risk factors. And then another example is looking at cyclosporiasis in a Pennsylvania residential facility. Okay, so we've gotten through a good chunk of study design. So I hope this helped you understand a bit about, one, this type of study depends on what your really research question is. Certain study designs are better to answer different questions. Also, it depends on data availability. You might not, almost anyone can do an ecological study, but because of publicly available data, but other data you might have to collect yourself and might be unavailable. And again, time and resources. A prospective cohort study is stronger, but takes a lot more time and resources. A retrospective is cheaper, but is less powerful. And so really, when you're designing a study, keep in mind that the aim is not to find the perfect study design, but rather a competent one that helps you answer the question and leads you towards solving epidemiological problems. And again, you can think of epidemiology, this is this triangle of interplay between the host and the host information, the environment, and whatever sort of agent, disease, injury, whatnot. And their interplay between them, and understanding those three with a proper study design will help you kind of ameliorate such issues of disease and other negative outcomes. So please take a moment to take the post-test. That'd be very helpful, as well as a survey that I have shown here. With that, here's some references. These are a couple of like the textbook references, or the quote references, some more general study design information. Then here are all those examples from the different study designs of studies or websites. With that, I'd like to acknowledge the DaCCoTA project that I work for. If you found this biostatistics, epidemiology, and research design core talk helpful, please acknowledge us in this manner. All right, well, thank you, and have a well-designed day.